Okay, good morning, everybody, and thank you to be here. The idea of this panel discussion is to be as much as interactive as possible, so we would be more than happy to try at least to answer all your questions and all your doubts. My name is Lorenzo Dagna. I actually come from quite far away from here, from Milano, Italy, and in my group we are probably following the second largest cohort of patients with Dagna disease, and we have some kind of also practicing research and specific treatments on this disease. I just want to take a couple of minutes from the discussion to give you a general overview of what we do for Dagna disease or the physician that take care for this disease. Actually, what is done is based on three main assumptions that you can find here. So, first of all, that this disease affects macrophages. Macrophages are one of the first-line cells of the immune system that actually patrol our organisms, and they try to eat foreign things that try to infect our body. And so they defend, normally they would defend us. The second observation that came out in research is that in patients with Dagna disease, inflammation, that is something that normally helps us to heal when we get wounded or to prevent infection, is uncontrolled. So the patient affected with this disease has some kind of inflammation that is not useful for the life of the patient. And the last observation that actually came out in the last year, mainly due to the research done by the group of Julien Roche in Paris and in collaboration with other groups both in Europe and here in the States, is that apparently there are some mutations, some genetic mutations that are present in patients, that can be detected in patients with Dagna disease. I will spend a couple of seconds on this aspect, but I want to point out, since I know that it's a question that a lot of people are asking, this kind of mutation are sporadic mutations. So at the moment we have no information about the fact that this mutation has been heard by a relative or can be transmitted to the son or a daughter of the patient. So this mutation is acquired throughout life. It's not something that is inside the DNA of the patient at the time of the birth, and so it difficultly could be transmitted to the children. On the left, you can see a typical cell with this appearance with a lot of globulets that are kind of droplets of lipids that are here. This is another disease, which is Langerhans histiocytosis, which is somehow similar, but in many aspects different. So, as I told you, the first thing that was considered is that as soon as these cells are macrophages, we have to target macrophages. And so what is done at the beginning? We start using steroids. We start using a drug that is called methotrexate that can kill macrophages, cyclosporine, different degrees of chemotherapies, and radiation therapy. Unfortunately, this early data, this early treatment has led to unsatisfactory results. So research has moved on, and one of the other steps was the use of cladribine, proposed by a group here in the States, a drug that is able to kill quite specifically macrophages, so these cells that are implicated in the pathogenesis. Subsequently, another drug was proposed again for a group here in the States and tested on a larger scale in Europe, which is interferon, which there's a general consensus that may be the first-line treatment for Dagna disease for patients with some kind of characteristics of the disease. After that, other studies have been proposed. One is with another drug called imatinib that interfere with some specific activity of the macrophages, and also another recent proposal by Dr. Vaglio, who's here in the table, which is called sirolimus, which is a drug that addresses some inflammatory property of the cells and of the infiltrate that is present. The second point, I told you, okay, we have macrophages, but we also have this uncontrolled inflammation. So these cells are activated. They seem to respond to something, although we have no evidence that something is there, and so that this response is needed. This is the reason for why I call this uncontrolled chronic inflammation. It's not connected to something helpful to the organism. And what we know by the scientific research is that there's a number of substances that those cells use to communicate one to each other. For example, when there is a virus infecting an organism or a bacterium, the cell asks for help. And the only way, I mean, when they find it, they ask for help from other cells in the organism. And to do that, they produce substances that are called cytokines and chemokines. So cytokines and chemokines are small substances released by cells in the tissue that cause other cells to enter and go inside the tissue. And we have done some studies on that and found out that some of these substances, namely interleukin-1, interleukin-6, and tumor necrosis factor alpha, are crucial in calling other cells. You can understand if other cells arrive to the lesion will grow and grow and grow. And this is one of the problems of the lesion with patients with Erdheim-Chester disease. The same substances also, they can do what is depicted here, so they can auto-activate the same cells. Namely, this cell produces this substance, and the substances are able to reinforce the activity of the inflamed cells. And since we have, for other diseases, typically the drugs that target these specific molecules are used in inflammatory disease, as you can understand, like rheumatoid arthritis, some kind of vasculitis, and things like that. We started with some results also, treating patients with some drugs, namely anakinra, Kineret, who is able to target interleukin-1, tocilizumab, which is Actemra, which is able to target interleukin-6, and infliximab, whose name is Remicade, that can target tumor necrosis factor alpha. So these 3 lines of treatment help to stop this inflammation. And the last slide will be about one of the most recent findings about this disease. And actually, again, as I told you before, the group by Juliana Roche in Paris described for the first time a mutation in a gene that is present in macrophages that cause Erdheim-Chester disease. And this gene is called BRAF. This gene has been described in other diseases causing cell proliferation. In this specific disease, is not able to cause cell proliferation, but probably is responsible for the activation of these cells. And this protein is present in a significant number of cells infiltrating the Erdheim-Chester disease lesion, as I show here. Here is a microscopic picture, and what you see in brown is the mutated protein, so the effect of the mutated gene. Normally, if you stain a tissue with this antibody, with this staining, you would see anything in brown. But this staining, this picture is taken from a patient with Erdheim-Chester disease, and all you see here in brown is the effect of the mutation that I just described. And the news about that is something new that mediated from different treatments. We have some drug. One is already available. It is called vemurafenib. Another couple of drugs and other future drugs are in development. And friends here from the Sloan Kettering Center Institute in New York are pioneering actually the research on this specific drug not only in Erdheim-Chester disease, but also in other diseases, could be available for treatment. So the situation is completely different. I remember when my group first started studying the pathogenesis of the disease, and actually we published one of the first paper on the pathogenesis of the disease back in 2004, there was nothing. There was nothing scientifically based to treat this disease. All the things that I told you came out after people like me, like colleagues here, like others that I've met yesterday, have studied and do research with that. And I can say that many of these results were also mediated by the help that you gave to us, also through Katie and all the Erdheim-Chester Global Alliance. So I think that the horizon is completely different from 5 here up to now. And I also think that in the future, things will be moving quite quickly. But I don't want to take more time from you, and I can move to the discussion.
We felt that there was a couple things going on here. One is that we were helping patients, which is the most important. Number 2 is that this trial is bringing patients to our center at a volume that we've never seen before. And so there was an opportunity, we thought, to assemble some of the scientists that we have and the multidisciplinary group of physicians to really not only just put people on this trial, but people that don't qualify for the trial, get other types of treatments, but also to engage some of the scientific talent we have to try to make the next breakthrough in the disease. And you can only do that if you have the patients in one of a couple places, like the work shows the work that you've been able to do. So we put together a big group. We have Dr. Dunkel, who's a pediatric hematologist that's worked in Langerhans. Dr. Abdel Wahib, who's here, is actually an extremely talented laboratory and physician scientist who's been helping us understand not just the BRAF mutation, but all the mutations that are present in these tumors. We have a dedicated pathologist who reviews all these samples. Actually, I just want to make another point here. We have a dedicated dermatologist, and Dr. Basalga is actually our physician-in-chief. So he's the head of the entire cancer center, and he's directly involved in this effort. That's how important he thinks this is. So this is kind of what we've arranged. We know that patients are coming from far away. So if you are interested in hearing more about the trial, you can call my office. You'll probably speak to a woman, Merlene. Again, it's an adjustment for her that it's not just ovarian cancer patients calling. So just identify yourself as having Erdheim-Chester or Langerhans or being a family member so that it helps me kind of sort the calls, or you can email me directly. And what we've basically been doing is we've been having the records and pathology reviewed in advance of any visit because we want to be very respectful of the time and effort that you're putting into this. And then if we think you may be appropriate for the clinical trial, I mean, we're happy to see you in either way. We would like to very much. But if we think you're appropriate for the clinical trial, what we can do is we can schedule all the blood work scans, everything kind of in a 1 to 2 day period when you come to the hospital, and kind of get you started quickly. And then visits are required to be once a month on the trial, which is a little bit onerous, but is I guess, unfortunately a requirement. Other things is that we've been offering retesting of BRAF mutations to patients who were told they were negative. We've found several patients that were positive, that were previously told they were negative. And we've also been, in the research setting, looking to sequence every single gene in the histiocyte, every single one. And with the idea that if we find other things that may be important for treatment for you, that we would certainly let you know about that. So I won't take more of your time. I just want to thank you. I know that one of the other things this experience has taught me is that having such a rare disease puts a huge amount of responsibility on the patients. It's not fair at all, but you guys have put together an organization like this that allows the research to be done. And that also, it's very tricky because if we don't make a commitment to putting patients on these types of clinical trials, what we're left with is defining therapies that may work, but that patients may not have consistent access to. I think it's extremely important that we make every effort possible to treat patients in the context of clinical trials, because that's the only way we can prove to regulatory agencies that these drugs work and that they can be approved. It's not easy because until recently there were no clinical trials, but now we kind of have this opportunity, and it's not, sometimes patients are coming to me when some of them may actually even be able to get the drug through their insurance companies, others have not been able to get the drug through their insurance companies, but they're making the effort to come in, and it's kind of a sacrifice that they're making for the whole community, and I'm deeply appreciative of that. So thank you very much, and I'm happy to answer any questions.
Hi, this is just an administrative question, I guess. I'm having trouble getting all the records, volumes of records sent to every place, slides and records, without having to pay for it. Are there forms where the clinical trial has a form that I can submit to the hospital where you're requesting the medical records so that they don't charge per page?
Hi, I noticed that your testing was doing stuff more into people who have the mutations in the brain. Have you guys done anything with people that the mutation may not necessarily show up in the brain, but in other parts of the body?
Absolutely. So only one of the patients on the clinical trial actually had a mutation identified in brain tissue. There are technical issues with testing brain material that are not that are difficult. So we've actually had more success in finding it in other areas of the body, and if it's in any area of the body, it's everywhere, and those patients can benefit.
Hi. This BRAF mutation, is this something that they're looking for when they test a potential lesion on the body? My dad's doctor wanted him to have, these lesions that some ECD patients have tested to see if there is a genetic component. And I assume it's testing for the BRAF mutation. Is that why they would do something like that?
Not really, actually. I mean, it up to last year wasn't definitely part of the testing that was done to this kind of lesion, even if the diagnosis of Erdheim-Chester disease was made. From last year on, I hope that most of the centers, most of the advanced centers dealing with this disease will do the BRAF mutation. But there are two major issues. First of all is that it's not obvious that the center has tested for it. So it's not part of the routine testing. Second is what I was trying to discuss. In many cases, the technique used for detecting the mutation is not sophisticated enough to reveal it. So in many instances, even if the results is negative, it should be important to retest the lesion to be 100% sure of the BRAF status of that lesion. So if the reports of the biopsy do not mention BRAF mutation, probably that wasn't done, and this is almost a rule if the biopsy has been taken more than 1.5 years ago. And second, even if it's cited as negative, it could be worth retesting with more sophisticated techniques.
How would you test if there are no lesions?
See,
How would you test for the BRAF mutation if there are no actual skin lesions?
it's not different from other sites or whatever. If you biopsy an Erdheim-Chester lesion, as David said before, as Dr. Hyman said before, actually you are supposed to have the same kind of cells in every part of the body.
I see.
So if you find the mutation in the skin, it's quite sure that the same cells are in the brain or in the bone or whatever. So.
We've actually, so just two small things. So first of all, I just want to clarify that this mutation is not an inherited disease. And I think that's very important. This is a mutation that's only present in the histiocytes. This occurred after birth. It's not something you inherited. It's not something you pass down. And so the testing doesn't create privacy risks or insurance risks for you or your family. I would encourage everybody who hasn't been tested to ask for the test. If it's positive, that's great. If it's negative, I wouldn't stop there. We found that biopsying around the kidney is the most efficient way to identify the mutation. About half of the patients that have kind of involvement around the kidney, that seems to give the highest yield. But I would ask, I don't know if
we have the same experience. We found that perirenal tissue can be positive. You don't have to, you just have to search. The thing is that probably we should be clearer in terms of which technique is used. Because at our center, so far, it's mainly molecular, it's PCR. Whereas in other centers, I know that there's a combination of PCR and immunohistochemistry. So this, of course, is a little bit too difficult for the patient, but for us, it should be like a point of discussion whether we can reach consensus on the type of technique or the combination of techniques. Anyway, the more sophisticated it is, the better.
Yeah, but I think, again, from the patient perspective, I think to the extent that you're obviously advocates for yourself, to advocate for the testing in the first place, and to not necessarily accept a negative test as the end of this avenue of inquiry. Did you have a question? Not here, an answer.
That's the question.
There's another question.
I noticed that one of the slides had a rash shown on the torso area, and that was from a Langerhans patient, I believe. Have you seen that type of rash in someone with ECD?
Yeah, we're treating a patient now with ECD in the skin, and there's been a similar response in terms of to the drug.
Okay.
Oh, yeah. So I'm sorry. So we've seen. Actually, it's interesting. You should ask that question because again, I'm new to this disease. So I asked that question yesterday of my more experienced colleagues because I had an Erdheim-Chester disease patient with a similar skin rash, and I said I hadn't read about this. Does this happen? And they both assured me that it does.
Well, that's, the reason I ask is because my wife had that, and nobody ever knew what that was about. There was no. They were just totally baffled by it, confused by it, and even when they diagnosed the disease at Mayo, they still didn't really make the connection between the rash and the ECD, even at that point. Later on, we found that there was a biopsy done a year prior to that when we were trying to figure out what was going on, and the pathologist actually mentioned in the report a possibility of ECD, but it wasn't relayed to us at that time because they were looking for cancer.
But I believe that anyway it's quite a rare manifestation. I mean, in our experience with 18 patients, we never saw one. And of course we did look at the skin because we know that it's a potential site. Maybe other centers may have, but overall it's a very rare manifestation.
We had one. I just want to say we had one patient who, and this is another kind of reason to consider. Obviously, I'm preaching to the converted in a sense, but to try to seek consultation at a center that sees a high volume or a higher volume of this. We had one patient who came to us with many, many years of only a skin rash, and she had just been told that she had this kind of benign this rash. Had been biopsied multiple times. They'd never arrived at a diagnosis. We actually went and did imaging of the whole body and diagnosed her with Erdheim-Chester disease. It wasn't apparent just from the skin rash.
I just want to add to that just a skin rash is not the only manifestation of Erdheim-Chester in the skin. You can have a granuloma, which is called a central granuloma, or you can have a reticulocytic histiocytoma. They look different, and they're all part of the same spectrum of the disease. We've tested a few of the patients that come in, and they have the 3 different forms of skin presentation, and they do have the non-Langerhans cell form with the adequate immunohistochemical staining pattern for Erdheim-Chester. So it's not just a regular skin rash. Other manifestations can be seen. They're not that common, though.
Thank you. I had a kidney biopsy 3 years ago, and it was recently tested and didn't show the BRAF mutation. Is that biopsy now getting too old to be useful, or can it be retested? Or
No, it's not a question of time. It depends really on how large was that biopsy and how, if all the materials that have been stored have been used for testing. But if still there's something less, the amount of material that is needed for this test is very scanty. So if they have something stored, it could be still used.
thank you.
Although we have been rebiopsying patients, and you know, if obviously there's adequate old tissue, we don't do it. We don't biopsy patients that don't need to be, but there is some degradation over time, and we have been biopsying patients and actually freezing the material, which allows us to get higher yields and more likely to have positive tests. I think that since this is becoming a crucial kind of treatment decision point, that I can't give you individual advice without reviewing your records, but again, I think it's important to kind of fully investigate this issue before determining that you're not a candidate for these types of therapies.
Okay.
First of all, I just want to say how terribly exciting this all is. When I was diagnosed in '01, there was no treatment. And to hear about this is just fantastic. I have two questions. One is, yesterday at the medical symposium, there was representatives of a company that said they could test the BRAF from urine. Is that, I'm curious to know whether you think that is, that simple process is possible. And my second question is, I think you should tell people about the potential side effects of the vinarafovine, so they have the full picture of the whole thing.
Yeah. Do you want to talk about the urine testing? Or? Yeah, I mean, there are companies now, it's clear that when you have a mutation in the body, in any cell of the body, that some of that material, genetic material, is shed into the bloodstream and is then actually excreted in the urine. And there's a company, Tovagene, that actually markets a test now available in the urine. I think that's still, I think it's useful information, but it still has to be considered kind of investigational. And it's not yet become a substitute for identifying the mutation in the actual histiocyte material, although that may change over time.
Also because, as Dr. Hyman said, this is a sign. First of all, I think that more studies must be done to prove the specificity and sensitivity of this test, but also is an information that this mutation is somewhere in the body. When we biopsy, even as we were saying before, if the patient has a multi-organ involvement and we biopsy a skin lesion of Erdheim-Chester, we have the proof that there's an Erdheim-Chester mutated lesion. So I think that at the moment we must rely on tissue biopsy and an analysis on the tissue to be sure for that. As far as the side effects...
So I actually, that was really an unfortunate oversight that I didn't include that. There are real side effects from vemurafenib. There's ones that are common, and then there are ones that that are less common, people are very concerned about. So the most common side effects we see are skin rash and joint pain, and to a lesser degree fatigue. And there's some thinning of the hair, although the patient that you saw the video had been on for almost a year and a half. And so that you get the sense that the thinning of the hair can be kind of variable from patient to patient, and is usually more mild. The skin rash is manageable, usually with interrupting the dose of the medication and reducing the dose of the medicine. And about half the patients you treated have need to have dose reductions. The joint pains are manageable, usually with interrupting the medication for a period of time and then restarting it. The concern, rightfully so, that patients have is about the risk for skin cancers. And we see precancerous or cancerous skin lesions in up to 15% of patients that are treated. We've had, in the 8 patients we've treated, I think we've had 2. So that just, or maybe it's been 1. It was treated with just an excision, like you would go to the dermatologist and have. And actually everybody that's treated with this drug on this trial is required to see a dermatologist before they start, and every 2 months that they're on therapy. And it's an issue. We've tried to select patients that have severe forms of the disease, and therefore those risks are, we feel, reasonable in comparison to the potential benefits. But it's something that we spend a lot of time talking and counseling about before we start.
Yeah, I think anyway, one should be reassured regarding this, because one might think that it has a benign disease, Erdheim-Chester is not a malignant disease, and then starts the treatment, and then it turns out that it's going to run the risk of a malignant disease. The types of skin cancers that appear usually after this type of treatment are not melanoma generally.
Never melanoma.
So it's melanoma the most frightening type of skin cancers, but all the others, if appropriately diagnosed and if the patient is on regular dermatology follow-up, they can be just cured by surgical excision. So you don't run a big risk if you are appropriately followed. This is my belief.
I would love to be a part of one of the trials, but one of the things that my doctor fears is we've got the disease under control with interferon. And if we stop the interferon to test another drug and the ECD starts up again, there's no real guarantee we can get it stopped.
It's a very good point. I'm going to defer to my colleagues that have had a larger treatment experience with non-vemurafenib.
Yeah, interferon has been for the past years one of the drug of choice. Yesterday we tried to find out a common position of all the physicians involved in treating this disease, and even although we haven't written down that, and hopefully that will be in the next week because we will continue this meeting and have connection between us, I would say that probably the first strategy would still remain at the time being interferon. So if a patient is on interferon and is responding to the disease, I would advise, again, now I'm moving to my personal advice and personal experience. We are following 30 patients, almost 30 patients, 29 with other chest disease. Interferon is the drug for which we have the long follow-up in terms of safety, efficacy, and whatever. There are some localization of the disease, for example, the heart and the central nervous system, that may respond less to interferon treatment. So clearly, what I would recommend is to keep on a strict follow-up. But at this moment, I don't know if David agree with me, if you are on interferon and you have a good response and the disease is under control and the disease burden is low, I would wait for switching to vemurafenib treatment. We have a long experience, I mean, we have a good experience. Their group have done this astonishing study with astonishing results, but the drug has been available, and the notion that the BRAF mutation was present in this disease came out just 1 year ago. So we have 12, 14 months of follow-up of this. We don't know what will happen in 2 years, 3 years, 5 years treatment, if we stop treatment, so at the moment, I personally would advise that people that are on interferon and have good response with the drug will still keep doing that. Maybe they could get tested for the mutation so that they know before that their mutational status is positive, so they could be ready to start immediate treatment with vemurafenib if needed. At the moment, I would then suggest keep on with the drug, keep on strict follow-up, and maybe be tested for the mutation, so if something will be needed in the future, you are ready for that.
Yeah, this is exactly the same strategy that we are following at our center, and that does not apply only to interferon alpha treatment, but also other treatments. I believe we have a patient who was diagnosed about 20 years ago, and he is now on few milligrams of prednisone, and he's doing very well. He was tested for the mutation because, as Lorenzo recommended, it's always useful to have a test. It's always useful to be even rebiopsied, even if you were diagnosed many, many years earlier, because the mutation may be like a help for future treatments. But I wouldn't change if the patient is really in well-being, but that must be well-being and has no disability. Another point I think is worthwhile being discussed is that this disease, after many years, causes damage that might not be completely reversed. So one should not expect that on the new drug, all the damage is, reversed. So think of this when you think of new treatments and when you expect new results from other treatments. So you might want to change treatment only if the disease is really active, if it's giving you ongoing problems, but if it's something that your neurologist or your doctor can attribute to a chronic damage, that it's not going to be reversed.
Hi. I'm wondering if you've seen any plateau in the patient response for those that have been on the BRAF inhibitor. So I think you said that 14 months was the longest time that someone has been on it. And have you seen, I mean, the MRI results are really great, and I'm wondering if you've kind of seen a plateau in how they improve over time, or do you have any idea how long that takes?
I think it's, I think the group that's probably had the most long-term experience is the French group. I think we don't know the answer to that question. I think that it's clear to me that there's some damage that is not entirely reversible in the brain. And so if you saw the patient, the video I showed, she was still not back to her, pre-diagnosis baseline, although she feels that she continues to improve even at this point. So I don't know the answer to that question. How long you can expect to improve on a therapy like this, I think it's probably too early to know. And especially when neural tissue is involved, I think it takes a long time for kind of repairs to set in. But that's just my kind of early sense.
Thank you. Thank you. I have a couple of questions. One's on the diagnostic side. I'm just kind of curious. In terms of, you mentioned you may get a false negative reading, and that, in fact, I would expect Sloan Kettering at least would have sophisticated state-of-the-art testing. Is there a valid question to ask? I've just had this done, and it came back false negative, or excuse me, it came back negative. And so then the question becomes, what do I ask the folks at Northwestern, in terms of the test they did to determine whether they're using a similar level of testing to know that, in fact, that's valid? Any thoughts there?
Yeah, this is I have to say it's personally extremely difficult to answer a question like this because there's so many factors that may affect the chance for a false negative. And I think the other thing I would say is that there probably are some true negatives. I think that's, and I think that's something we still need to find out. But the age of the tissue being tested, the purity of the tissue being tested, and the technique used, the quality of the molecular pathologist, it's very hard to answer this question generically. And I think it's something that, may even require kind of a second opinion or maybe even retesting in a different lab. I think it's very hard for a patient to say, what assay did you use and what's the sensitivity of your assay, and show me all your data. And to be honest, even at Sloan Kettering, we've been wrong. And we've had to go back and revise our testing procedures for these patients.
Okay, thank you. Second question is maybe a little bit complex, but as a group of physicians that have looked at this disease for a while, have you seen patients with multiple diagnoses, something like starting off with multiple lymphoma, moving into an autoimmune kind of Sjogren's disorder, connective tissue disease, and then ultimately coming up with third-time Chester? Are you seeing things like this, or am I unique?
No, absolutely not. Not unique. Actually, the guy who is standing just behind you yesterday showed the list of potential, am I wrong? A potential association of diseases with Dagna. In our experience, there is a few patients with diabetes, a few patients with a pre-ECD diagnosis of cardiovascular disease. There are autoimmune diseases, autoimmune thyroiditis that can be associated, and then of course everybody has some. But I would, you raise a very important point because everybody focuses on, of course, on the diagnosis, testing mutation, finding treatment, and so on. But we need to think of other possible complications and address single questions. For instance, cardiovascular. Yesterday we spent a few minutes talking about cardiovascular disease. You should undergo a proper cardiac evaluation. If you have a coronary stenosis, you should treat it. If you have a carotid plaque, you should treat it. If you need to take aspirin, you take aspirin. So all the supportive, let's say, treatments should be done and are as important as the treatment for the disease. Rehabilitation is very important for muscle strength and nerve regeneration. I mean, it's really in our hands. It's a multidisciplinary disease. And so this tells us that we should not just address the question of the main treatment, but also other treatments should be done.
Thank you.
Yes, hi. Now I'm just unclear about whether my son should try. He does have the BRAF mutation. We just found out a few months ago. He's 39, and he was diagnosed probably when they finally found out what was wrong with him in 2011. He has it in the granulomas in his brain. So his speech is affected, obviously his balance, so he's afraid to walk, so he pretty much stays in a wheelchair. And so he was on anakinra, and then he was on interferon now for about a year and a half. Right after he was on it, there was improvement on his MRI on his brain, but since then it's pretty much remained the same. And his doctor said that if they have that BRAF mutation, that they found that maybe the interferon doesn't do as much for them with the people with that mutation. So should he be a candidate for the mutation or not? Now I'm not clear.
Yeah, no, I mean, it's tricky to give individual medical advice in this setting. I think we had a lot of discussion about this exact point yesterday. I think there is the perception that lesions in the brain are most resistant to therapies other than vemurafenib. I mean, I don't know what your experience has been. That may not even be a fair statement. I guess what I would ask in the kind of conversation that I have with patients in this regard is putting aside scans for a second and what your doctor says is happening to you. How do you feel? Are you getting better? Are you getting worse? And is this level of function something that is manageable for you? And I've seen a number of patients who were told that their disease was stable on interferon, but felt that they were getting worse and worse over time. So I think this is an area where we really need to listen to patients and hear what they're telling us and not just rely on an MRI scan to dictate care. But again, I have less experience, so I'm going to pass on.
Yeah, my comment on that is that interferon was the first, apart from cladribine, that generated some enthusiasm, at least at the beginning. Interferon was the first drug that really showed efficacy in Erdheim-Chester disease. Then there was a report saying that from some localization, namely the central nervous system and the heart, interferon couldn't be that effective. But then again, it has been shown that interferon, especially high-dose interferon, is effective also on central nervous system and cardiovascular manifestation of the disease. With all the limitation that could be done due to the fact that the number of patients that we can study is extremely limited, so all the studies, the statistics that medicine usually do to say that if something is true or not, but the only evidence so far that we have for treatments is that interferon is associated with an amelioration of the disease, with the disease going better. I agree with Dr. Hyman on what he says. I'm not curing an MRI image. I'm curing a patient. And we have to take account not only of the potential progression of the disease, but also of how the patient feels with that specific treatment. I give you an example. The last patient that I put on vemurafenib in Italy, and we have quite a problem for doing that because the drug wasn't available up to a couple of months ago, was on interferon and was doing definitely better, but he was feeling so bad for the drug. And his life was almost impossible with this dose of the drug because, again, high doses are needed to have a good response. Mm-hmm. And we switched him to vemurafenib. That's because even if there was a kind of, again, amelioration of the images at MRI, but the patient wasn't feeling well. So it's a complex evaluation that must be done on a single patient basis. So it's quite difficult for us also to provide personal information here in this setting.
Right.
But take accounts of a lot of things, of which, I mean, the fact that MRI is better is just one point. And the other point that we must take in consideration, sorry if I stress this, because I am really impressed and enthusiastic about all the work that they have done and all the dedication that they put on that, is that we must be thinking that we have short experience with this drug. So this drug is extremely valuable for people who are not responding, who have a problem, but we must think 1 second before completely saying, okay, for everyone. If I'm not an oncologist, I'm an internal medicine physician, so I go get back to him. This drug was developed originally for metastatic melanoma with this BRAF mutation, but it's not a first-line drug at the moment. There are other treatments, and then you can move to that.
I mean, it's become the first-line drug for melanoma, but it's a different situation. I mean, melanoma is a disease with a very limited expected survival, and so it's a non-comparable situation.
And then it's becoming the first line after years and years of experience.
Yeah.
And this is what at the moment we're like, maybe in 1 year, 2 years from now, we'll be saying that BRAF would be the first line for everyone, BRAF inhibition. At the moment, we do not have enough evidence, and unfortunately, in many cases, problems have arisen later. I think it's a great drug. It's something that is giving huge promises for a person that have a condition for which I, as a physician, having in my hand interferon, some anti-cytokines drug, couldn't say nothing. We need studies like the one that is done by the Sloan Kettering colleagues. And with this data, maybe in 1 year or 2, we will be able to more safely give advice. At the moment, again, as I was discussing before, I would advise that people that are responding, people that are feeling well with conventional treatment should, for the moment, wait for more data to be accrued.
And I think that also speaks, and again, I've seen this firsthand. I know the sacrifice the patients who are on this trial are making in some cases to travel long distances, but it also speaks to the importance of gathering this type of information on the efficacy and long-term outcome as part of a clinical trial. Because for every patient, first of all, that can get the drug, there's another one who can't. And on top of that, we really won't know the answers to the questions about how long will a patient continue to benefit. You know, how long do they have to be on therapy before they've received the maximal benefit of therapy? What happens with all these issues? What is the safety in this patient population? Unless we collect it in a formal way.
I would just make a further comment on this rapidly evolving situation. About 3 years ago, we didn't even know that such an opportunity of treatment would have been available. So my comment is sort of a positive comment. We are searching for many other mutations. There are many other inhibitors. So one should not think, okay, I do not have the mutation, I have no chances. They have reported another mutation. They have a panel of mutations that are being tested, and I think some results will come soon. And probably some patients might have even concomitant mutations and being treated with combination therapies. So just look at the future as a probably a future rich in many opportunities to have different treatments and just not be, feel sorry because you do not have that chance. Many other chances might come in the future. I'm a nephrologist, and kidney disease is a more stable field. It's like we do not have so much evolution. But if we look at our colleagues in hematology, in oncology, we can really see that there's a revolution. I think hematology, for instance, with new drugs like imatinib or any other drugs, have really changed the perspective of some diseases that now are being treated really in an effective way. So I think there's hope for the future, for having new drugs and new mutation tested. And I think we can should have a break. Anyway, we can keep on discussing on the same topics in the next session, I think.
There will be also time for a general discussion at the end. Thank you very much.
Thank you.
So we'll do a quick 5-minute break. We're going to, looks like there's a lot of interest, which is great. So just